spend too long introducing me.
Yeah, so I'd just like to introduce Professor Andrew Murphy, who is Professor of General Practice here in the university and also a general practitioner out in Turlockmore. He is the Director of the Primary Care Clinical Trials Network, and he is here today to speak to you about what the Primary Care Clinical Trials Network can do for you, talk about the background of the network and the progression to date. So we'd love if there was any interaction and any comments that you'd like to give. So please feel free to give some comments, and I'll hand over to Andrew.
Thanks very much indeed, Martha. That's great, and thank you for that. We might just check that folks can hear me okay. So if you just type in a message, and because we're a small group as well, we can unmute. Martha might unmute folks if they have a microphone as well, so we can make sure that everyone's receiving us loud and clear. I'm only one part of a two-parter with the good wine coming later. So my good colleague Lisa Hines will be talking about the My Comrade Plus study in about 15 minutes. As ever, we will finish up 1:45 to give folks time there. So I've got a message from Sinead there, which is great. And Maggie, we might see if you can put one in. So what I'm going to talk about, hopefully, is really just trying to receive feedback from yourselves about the network. And so that's why we'd be very keen for participation, either through microphone or through typing. Have you been able to unmute, Martha?
Yeah, you can unmute.
Okay. So
yes, I'm unmuted, Andrew.
So too much back thing. So certainly we can use the typing then to go. So that's the sort of thing that I hope to cover with it. So perhaps with the typing, you might just, we're interested in different types of studies, obviously, with the network. And these are examples of different types of studies that we've had over the last year. And I'd just be interested if you typed, and I'll talk about them, which sort of these studies you'd be interested in, and perhaps and why. So the first type of study, A, for patients with cardiovascular disease, is a regulated clinical trial. That's a very intensive program. Because it's a regulated trial, we had visits to the practice from the study organizers. I was reported for not completing forms up correctly, very heavy duty, but it was a very important piece of work. You might have seen that it's beginning to come into guidelines now. It was eventually published in New England Journal and showed that adding a NOAC to patients with established heart disease with aspirin was much better than aspirin alone, and I think will change practice. It also was profitable, it was very well funded, and certainly the practice made a good profit from it. Next up is very much perhaps a light touch study. We just had to produce lists of patients at high risk of AFib, and then great colleagues Martin O'Donnell and Rory Waters put on a week-long loop recorder, which was clinically responsible with Martin O'Donnell's team to identify those who had occult AFib. A study then, again, very light touch, but it also fulfilled the medical council criteria for audit, was looking at patients with diabetes, again using a practice list, was in external initiatives supported by the practice team. The practice, by the research team, I should say, had relatively little work to do, and the aim is to increase retinal screening rates for patients with diabetes. As you know, in Ireland, we're only about 50% or so, and again, this was a nice one that fulfilled our medical council audit. Final one then was a much more intensive study, really. It's looking for patients with dementia and their carers, whether providing a psychosocial sort of resilience building intervention improved outcomes for patients and their carers. The practice had very little to do with that component. They had to identify the patients and for it, but the practice did receive an educational intervention. And obviously the whole area of dementia, particularly early on, is sensitive. So of those 4 studies, would folks just type in which studies would click their fancy and saying, yes, I would be interested in doing that study, or I would not touch that with a barge pole. Anyone able to type there? So Sinead, your discrimination features are difficult, I guess. What I'm sort of thinking about is, firstly, as a network, we will offer different types of studies, and I think it's good that we do. But we're beginning to get some sense of which studies seem to be more popular than others. And as ever, as a network, we're interested in how to support those particularly. So that, in rough hand, I think the ideal studies that we seem to find that are popular they're very common, so it's easy to identify. So incident cases of tonsillitis, for instance, or respiratory tract infection, or prevalent conditions such as diabetes are going to be much more attractive, it would appear, than obviously, take an extreme example, motor neuron disease. So people like studies that they can get numbers into them. And based largely within general practice, some of the studies that we've looked at have asked patients to come to the hospital to do things. And again, patients and practices aren't fully supportive of that. So I just see, Martha, that Najai has a difficulty with hearing, so that may well be his own.
Yes, unfortunately, I think that would be his own
PC.
PC. But if you would like to call in via his telephone, on the email he was sent out, there should be a phone number that he could ring to join in. All right.
And a key one is workload. And some of the studies, as I've said, the first study, the regulated trial, we actually hired a practice nurse to provide specific hours. It was that heavy on workload. But as I said, because it was an international trial, it was actually well funded for it. So workload is important for these studies. And then secondly, the IMC audit is a key component as well. And clearly, it's nice to have things of very real relevance to general practice as well. And ideally, we find if we're involved in the studies early on, we can shape them to fulfill these criteria. It's very difficult when we get studies that are later down the tubes. And obviously then a nice bit is if that they're very well funded. And that doesn't happen all the time, unfortunately. So those are the sorts of studies that we want to discuss with you a little bit more. Just give you some background, and I won't spend too much time on this, and that basically in Ireland, we weren't doing as many trials as we probably should be. In the European context, colleague Adele Murphy did a systematic review looking at the number of primary care trials in Ireland, and we had done about 13. In the Netherlands and the UK, if you adjust that for population size, we're less than a third of what they were producing. When we do them, we tended to get them published in good journals, so the quality was good, but not the quantity. So there certainly did seem to be a need for a trials network to support this sort of thing. And as many of you may be familiar with, where the trials network came from was the HRB had a competition looking for people to apply to run a trials network. We combined with our colleagues in RCSI, the Irish College, to form a research network, and then for this actual call landed in with all the other university departments, Northern Ireland, the HSE, and we got funding for this trials network, and that was in July 2015. And as part of the funding, there was 2.5 key studies that we were funded to do, but the key bit that they wanted us to do was to be a source of support for ongoing trials, and that's the over here. Looking at the new trials. And I guess that's what we're focused on today a little bit. I've got some slides that I'm going to do very quickly through, which is bad practice, I know, just showing the range of trials that we've got, because I do want to get your opinions on how best we can support the delivery of those. So the exemplar trials that we had was a trial looking at antibiotic treatment of urinary tract infections. Trials are risky. Some new evidence came out and we had to abandon that about 2/3 of the way through. Susan Smith and Caroline McCarthy have done a great trial on medicines management in older adults. It's going to turn out to have more practices than any other trial ever in Ireland. They're up to over 100 practices have been contacted on it, and it's close to finishing up. And then Paula Connor did a very nice study north and south of the border on patient safety. So those are sort of what we were funded to do. But as I said, what is of interest today is what other trials has the network attracted to it. And that was the COMPASS trial was the one I referred to, very high profile trial that was there. Heart failure we're looking at. One that Sinead would know well would be Alice and Mermaids. And again, very pleased with the recruitment figures that we have for those international trials. And then we've lots of other trials: resistant hypertension, diabetes, dementia. I mentioned about the loop recorder for patients at risk. And then we have a lot of allied health professional trials. The REDO one, again, Sinead would be familiar with, an occupational therapist looking at stress management in adult females. So the difficulty, in a way, isn't the number of trials, it's trying to see how best we can support them. So if we look back at that old systematic review that was done, we can see that in the 4 years since the trial network was set up, we've had 22 trials. So in 4 years compared to 18 years, we've had more trials with over 3,000 patients recruited. So again, to be fair, some of these trials would have occurred even without the network, but I think it has been a key piece of infrastructure supporting issues. But today is about trying to hear a little bit, and please type in on this. I mean, how can we support? The two key bits that we would see is the question generation and then engagement with practices, how best to do this. At the moment, with regards to question generation, we try to be part of international consortia, and then we sort of put in our own applications and see what comes in. And, you know, I think we should be doing better. So I would wonder about trying to hear from practitioners like yourselves as to what questions we should be looking at. So this refers to when I refers to you, if you like, about how do we generate high quality, relevant and feasible questions. And again, if folks could type on this, I mean, you know, would you prefer to have nothing to do with this by being on the webinar? I think you're interested in the network. Would you say, listen, just send me on the emails and I'll have a look at them. I don't want to do any more than that. Would you be interested in a meeting on it, specifically devoted to it, or attending something like the ICGP AGM or bespoke? So again, Sinead has indicated the email and then bespoke CME group. So I'm actually speaking to the CME tutors on Friday. They're in Galway. So that option to me seems like a reasonable option. I know the CME group are very understandably defensive on what gets into their bits, but I'll certainly be suggesting that to them. Yeah, and I think again the issues about the meetings is a key one. So those are the sorts of things that we're thinking of. If others have any other options, please just do type in. The next bit is then, once we have the research questions, how do we engage with practices to participate in the research? And again, currently, I think it's fair to say a lot of our engagement processes are directed more towards researchers and research practitioners rather than the key host, which is the practices themselves. So we do have the webinars like here. To be fair, I think we've got the technology working okay, but we haven't broken into huge numbers, and we have to look at that, I think. We've training awards, but they tend to be geared more towards researchers. I think of interest is that we do have a funding package coming down. That's the last bullet point there, supporting data quality in practices, in which we will be advertising for practices who are interested in conducting research to give them funding from 2,500 to 5,000 just to support their data quality, which for most practices I think they will be doing already themselves, of just coding. And we might pick a certain index condition to do some work at. And we'd hope to be advertising that over the summer, and we'll be in touch with you about that. So that's what we're doing currently, but what suggestions would you have? How best would you like to be engaged in supporting research? Again, just to continue to respond to the emails, would you like somebody from the CTN to have a video conference with the practice to explain what's going on? Have a practice visit? parallel meetings, bespoke CME on completed research. And that would be sort of saying these are the trials that we've done, or a CME meeting to discuss trials looking to recruit. So Naji, and I hope I've got that name right, is indicating about the webinars, so that's good to hear. I guess it would be nice as ever if folks, if we could penetrate a bit better than we are, but we have to think about that one. And Sinead is indicating about the coding, so I think that's good. We hope to link in with the ideas that there would be 4 practices in Galway, supported 4 in Limerick, 4 in Cork and 8 in Dublin, and that we would have a research fellow who would visit the practices and support them in the coding of it. And obviously we'd try and work together so that we'd have 20 practices that we could then say are all coding in the same way. So that's nice feedback. Thank you for that. And again, sort of support for the CME. So let's hope I don't get too savaged at a CME group on Friday. I always think they're a very robust and strong group, which is good. So that was a quick run through, I guess, and just trying to say that, you know, the CTN is up and running now 3.5 years. We have recruited a lot of patients, but I do think the whole issues about how we ask questions and engage with practices is ones that we haven't sorted out. Reassuringly, often other networks are struggling with the same issues. So I really appreciate your feedback on those, and I'll bring that certainly to the group. Without further ado, and again, if anybody wants to contact me, there's my email on the issues that I've raised. I do like swimming in Salt Hill, but I don't think I'd be swimming on that day that we took the picture on that. So delighted to hand over to good colleague Lisa Hines, who's a postdoctoral researcher running the My Comrade Plus study. I see Audrey Rankin from Belfast has joined us, so you're very welcome, Audrey. I know you've particular interest in this area. Lisa's a health psychology, and we're really delighted to have her working on this project. Over to you, Lisa.
Thank you. Here. Thank you so much, Andrew, and thanks to you all for being here today. I'm delighted to speak to you a little bit about one of the studies supported by the Primary Care Clinical Trials Network Ireland, which is My Comrade Plus. My Comrade is the multimorbidity collaborative medication review and decision-making intervention. And My Comrade Plus is a pilot cluster randomized controlled trial that we're running at the moment for about 2.5 years, and I'll go into that a little bit more as we go on. So the aim of My Comrade is to better support GPs to manage the multiple medications often prescribed for people living with more than one long-term condition or with multimorbidity. Sorry.
So you have to correct this.
Okay. So as you all will be very, very much aware, multimorbidity is a very significant and growing problem in general practice at the moment. Over 60% of people attending primary care are living with multimorbidity. So you'll be very, very used to dealing with someone like, we'll say Mary here, who was living with multiple conditions including osteoporosis, osteoarthritis, type 2 diabetes. The numbers of conditions can really add up very quickly, each of them associated with their own list of recommended medications to be taken at different times of the day and under different conditions, with food, without food, all of those kinds of things. So really things get complicated very quickly, and there are a huge number of things for you to be considering when you're working with someone like this over a long period of time. And added to those medications, then you also have lifestyle considerations, as well as maybe ongoing management and testing considerations as well. So multimorbidity brings up a lot of challenges from the perspective of the healthcare provider, the health system, and of course the person living with multimorbidity themselves. One of the main challenges is the management of those multiple medications, which bring with them the risk of adverse events, drug interactions, and also it really make it very difficult for a person living with multimorbidity to be able to adhere to their treatment every day and over time. So in primary care, there's a constant balancing act between wanting to reduce the burden of management for people living with multimorbidity and minimize numbers of medications and treatments, but also wanting to follow treatment guidelines. But as I said, and as you're aware, this issue of multimorbidity is only increasing, and rates of prescribing multiple medications has really exploded, particularly in the last 20 years. So it's an issue that's growing, but that the literature, the research offers us very few solutions to. And there's a strong call at the moment to better understand this issue and offer better interventions for supporting general practice, particularly in relation to medications management. So background 2012, Carol Sinnott, an academic GP, and this work was done in UCC, but Dr. Sinnott is now with this institute in Cambridge. So Carol and colleagues began work to understand what was going on in relation to the GP experience working with people with multimorbidity. And so 2 qualitative studies were undertaken. One was a qualitative synthesis of what was already out there in the literature, and another was a primary study. So the first one here is a system, or a synthesis of existing, thank you, qualitative research, thank you, to try to understand what the literature was saying about GP experiences managing multiple medications and multimorbidity. And there was a number of key themes identified. For example, the challenge of working with guidance, evidence-based guidelines for managing conditions, which, as you know, deal generally with one condition at a time. And the overarching theme was that GPs were reporting that they felt unsupported, they felt isolated in managing people living with multimorbidity. Then a primary piece of research was conducted to understand what was going on for GPs in Ireland. And what they found was that GPs often accepted care that they deemed to be satisfactory and sufficient, even if they weren't happy with some aspects of their treatment plan. They tended to avoid changing a treatment plan if they saw the patient as being stable, and they reported that open communication amongst other providers and with their patients and patients' families, as well as continuity of care, getting to know their patient over time, were things that really helped in the management of multimorbidity. So these 2 studies were really the basis for future intervention development. This was the piece of work needed to understand what was going on in general practice in relation to multimorbidity management, to be able to design an intervention that might help. So, based on this work and some tools in the whole area of behaviour change intervention development, some work was undertaken to understand what needs to change in relation to the management of multiple medications and multimorbidity in general practice, and how this might be changed. So the first step was to develop a list of behaviours, GP behaviours related to medication management and multimorbidity that might be amenable to change. Then to select one of these behaviours and to study, really understand that behaviour. That was most likely of the list of potential behaviours to change and have an impact in terms of improving the management of medications. And the behaviour that was identified in this process was active medication review by general practitioners. And then the next step was to actually go ahead and develop this intervention to support behaviour change in general practitioners. And this is how we came to the My Comrade intervention. So the question that Carol Sinnott and colleagues asked themselves, based on the work that they had done at this stage, was why does medication review not happen in multimorbidity management and primary care? So to understand the obstacles in order to be able to attach intervention components to these obstacles. So the answers to this question, based on the data, were uncertainty about medications that were most valuable, the perceptions that patients will be unwilling to change long-term medications, a lack of time to properly review medications, an instinct not to rock the boat with their patients, the opportunity cost of using time in consultations to conduct medication reviews as opposed to all the other things that need to be done, and also a fear of not making consequences of making changes. So with these in mind, the components of the My Comrade intervention were put together, and the real key one is that first one, the collaborative peer supported medication review piece. So the centre of the myComrade intervention is the feature of bringing together GP colleagues to review the medications prescribed to a multimorbid patient together. So the issue here is that, as you saw at the very beginning, GPs feel isolated. They feel like they have an impossible task and very little support to do it. But what's happening anyway is GPs often, jump into each other's office or catch each other over tea to talk about these complex patients, complex lists of medications, and get support. So myComrade really tries to formulate the process, or formalize the process of peer support related to medication reviewing. Intervention also involves the GP pairs who get together to review the medications using a prescribing checklist to help them to work through the reviews. And that could be considered a prompt or a cue to the behaviour. Also develop an action plan for reviewing, so set aside time in a formal way and put it into their practice IT system, that they will sit down during that time every week or whatever it is to do the medication reviews. So that's allocating protected time to conduct the reviews. And also that this reviewing act could be recorded as an activity to fulfil their continuing medical education requirement. So those are the components of the myComrade intervention, and they were developed based on research and using behaviour change intervention development strategies and guidance. So then that brings us to the current study. So a funding call came out not so long ago from a group called CTNI, which is a cross-border healthcare intervention trials in Ireland network. So their remit is to support health intervention trials across the border. So myComrade Plus is one of the studies, one of the 11 studies currently funded under this project. And as a result, we have partners in Queen's and in the Belfast Trust working together on this project. So this is what myComrade Plus cluster randomised control trial looks like. The trial is going to take place in the Republic of Ireland and Northern Ireland over about 2.5 years. We're going to recruit 8 practices in the south and 8 practices in Northern Ireland. And we're going to be looking for people for patients on 10 or more medications, about 20 per practice from these practices across the border. We're going to be interested in treatment burden, in quality of life, in the riskiness of prescribing and the number of medications prescribed to patients, and looking at that at baseline and 4 and 8 months later. We're going to randomly allocate our practices to one of 2 groups, north and south. So 4 practices in the south and 4 in the north will be in the intervention group. So that's the group that are going to use the myComrade intervention and partner up for medication reviewing. And then 4 in both regions in the control group. A key feature here, because it's a cross-border trial, is the use of practice-based pharmacists as the other half of the pair with the GP in Northern Ireland, because that system is up and running. So it'll be interesting from a southern perspective as well to see what that throws up. Okay, thank you. Okay, so that is the trial. Because it's a pilot trial, as well as looking at those outcomes, we're also going to be looking at acceptability and feasibility. So is this intervention something that GPs and practice-based pharmacists in the north can use and get some benefit out of using if they do use it? And we'll use all this information to design a larger scale trial in future that will tell us more about how effective this approach is in supporting medication management and multimorbidity, and in 2 very different health systems. So just to finish up, thank you very much for listening to that, and we're really keen to get your feedback. So the key thing here, I suppose, is that this is a cross-border trial, and the funder is most interested in border related research. So in the south, we'll only be recruiting in Donegal, Sligo and Leitrim, and that'll hopefully be starting in the next month or so. So if you're not based there, I'm sorry, we won't be able to invite you to consider to take part in this trial. But if you know anyone who is based there, we'd be delighted for you to share some information about myComrade Plus with them. We'll be recruiting soon, as I said. We do have a lot of development work. All of that work is published that has brought us to this point in terms of the development of myComrade. We'd be delighted to share those papers with you if you are interested. So please contact me or the network, and the email is over there on the right. we're going to have some events and updates published through our different platforms going forward. We'll have a dissemination event for the study in a couple of years as well, so please keep an eye out. As I said, share this with your colleagues, share your thoughts by email or through Twitter with us, and thank you again very much for your time.
Well, I might just join in there, and again I'm very conscious with time of not running over too much, but as I'm just talking on one or two things, Audrey, you might type in, if you're able to, how are pharmacists based in general practice, that initiative in Northern Ireland, how is that rolling out? Any early messages there you might share with us would be tremendous. Logistics for others is, Nanji, thanks for your question about the survey. And yes, we will be compiling those and we'll be hoping to release that in about 2 weeks or so to folks. So thanks for anyone who participated in that. And as regards CPD points, as ever, Martha will be emailing those directly to you within the next week or so. And just on the My Comrade Plus, just to say that I've certainly found looking at this trial very interesting. The way of identifying patients, which is handy, is I use Socrates, and in Socrates, under the report form, under the research section, the SPIRE study has a finder tool that you can, it finds patients on certain numbers of medications. So that's how patients are being identified for My Comrade Plus, but you can use that in your own practice. You don't have to be doing the study at all. And the SPIRE study actually is looking at patients on 15 or more medications. So you can really narrow it down if you want it even higher than that, and could do an audit on those patients within your own practice if that's helpful. So thanks, Audrey, for that. So about 300 pharmacists, so it's a really significant initiative that's going on there, so we're delighted to be participating in that as well. So folks, conscious this is designed to be a lunchtime talk in between. If there's nothing else that anybody wants to fire into us, very many thanks for your tuning into us, and it's goodbye from Lisa, and it's goodbye from me and Martha as well. So many thanks indeed, and have a good day.